as I was thinking about the talk, and I actually have another case embedded in the short presentation to you today, there's probably also something to be said for the fact that many of our IBD patients tend to be younger. And so there can be either the identification perspective if we ourselves are a little bit younger, or as we age, we're looking at these individuals who are in their 20s and 30s, and maybe we're seeing our own children in them. And speaking as a palliative care professional, I mean, I know that it tends to be more difficult caring for a dying 20-ish, 30-ish-year-old patient than it does for a 93 or 100-year-old. There's fundamental differences that I don't think we can deny in those cases. So I have no financial disclosures to acknowledge pharma does not chase down palliative care or ethics consultants. We're going to sort of utilize, we've already started with that case example and touch on one more and explore the concept of how do we ethically and fundamentally approach the care of patients who refuse. What lessons can we take from our social work colleagues? And actually, one of those was mentioned, and even in the prior talk, going where the patient is, figuring out what drives them, what makes them tick, and then acknowledging this concept of psychosocial futility, which is something that we don't oftentimes acknowledge. We know it when we see it, but we may not always know the name behind it. So what drives us as healers? I already mentioned some of the personality traits or the emotional inclinations that we have in caring for these patients, and I think those arise from a historical perspective in terms of what we are compelled to do in medicine and what's also probably ingrained in many of us. And I'm a little anal retentive. If I'm asked to give an ethics lecture, I'm going to include medical ethics slides. And this is a slide I include in essentially every one of my talks. It's the guidance that Hippocrates gave to us in medicine when he wrote in The Science of Medicine, the complete removal of the distress of the sick, the alleviation of the more violent diseases, and the refusal to undertake to cure cases in which disease has already won mastery, knowing everything is not possible to medicine. So how do we paraphrase what he was writing several hundred years before Christ? Well, the first is the complete removal of the distress of the sick, alleviation of suffering. Hippocrates saw that as his first goal. The alleviation of the more violent diseases, cure what you can. And then furthermore, don't attempt to cure cases in which disease has already won mastery. Now, that's very easy for Hippocrates. He really didn't honestly have a lot of therapeutic tools. What did he have? He had what they refer to as meconium, which was poppy juice. So he could alleviate the suffering, but he didn't have biologics. He didn't really have all those other things. And we also have to acknowledge that you fast forward to 2019, and this notion of discerning which patient is overmastered by their illness is increasingly difficult. It's hard for us to know. So upholding those principles becomes difficult. By the way, I'll also make this one mention the fact that when Hippocrates, or we look at historical references to ethical principles, this is for medicine at large. Okay, these are not physician ethics. These are medical ethical principles. So if there's nurses and allied health professionals in the room, this is for all of us to bear witness to and to seek guidance from. And where can we turn to guidance in terms of difficult situations? We can turn to the field of medical ethics and its subsidiary, clinical ethics. Clinical ethics is the approach that we have historically taken at Baylor University Medical Center and what is increasingly used in many situations. Medical ethics is just a very broad philosophical field that pertains to what's right or wrong and those means to achieve those within the field of medicine. Okay, it's somewhat philosophically based, and we're going to touch on some of those principles. Clinical ethics takes the concepts of medical ethics, the core principles, and then it mixes them in very fundamentally with the clinical facts of the case. So the advice and the counsel we provide is going to be very dependent on the clinical facts of the case, incorporating social, religious, spiritual perspectives of the patient, cultural perspectives, and then whatever legal or health law constraints may exist. So clinical ethics, the point of it is to give practical guidance to practitioners at the bedside that they can actually use, as opposed to an 8-page note that waxes and wanes about principles and Hippocratic philosophy. So what are those core principles? The first is respect for persons. And many of these you're going to see, with the exception of one, autonomy, have a biblical, historical, faith, religious-based perspective. So respect for persons is simply treating another individual the way we would want to be treated ourselves. Very fundamental. As a matter of fact, if you talk to some ethicists, they don't really acknowledge respect for persons. It's somewhat ignored, not in a negative fashion, but it's just assumed. Of course, we're going to respect other individuals as moral beings. Beneficence and non-maleficence, we always consider those in tandem as they are interrelated, the notion of doing good to, for another individual, and the avoidance of harm. What drives a lot of the Hippocratic tradition and his teachings, and probably the rise of the majority of our angst. Here we are trying to do good, and in the treatment of IBD in these situations, doing good is also avoiding the harm that we know is going to come your way. Oh, and by the way, we may also inflict some harm on you with some biologics to boot. But how do we find that balance? Autonomy, which many would contend is the top or the most important principle in Western medical ethics. I would push very hard against that. We look at the ethical principles as being all equals. One should not outweigh the other unless there's a very strong, compelling reason that one of these principles should be subdued in preference for another one. It is very Western, very secular in its origin. Therefore, it's the newest of our principles. So it's the youngest of our principles. And it basically is the notion of self-governance. Derivative things that come out of autonomy are things like HIPAA, things like deserving and anticipating and needing correct information, a diagnosis, prognosis, what are my alternatives? So it's really kind of an information system. It does not trump the others, nor is autonomy universal. Okay, so there are limits to autonomy. We're going to touch on those in a bit. Justice, really, there are arguments for justice. We refer to this as distributive or social justice. This is not retributive justice. This is not punishing patients. This is a notion of how do we in medicine balance the needs of our society as a whole, not necessarily in opposition to the needs of the patient. Okay, this is not meant to be an oppositional concept. It's mainly focused on how do we uphold equanimity? How do we treat everybody equally? And then fidelity. And fidelity is not exactly the opposite of justice, but fidelity is really the covenant of trust between the practitioner and the patient. Now, this is a two-way street. Oftentimes when we think of fidelity, we think of this as our devotion and our commitment to the patient. But I would argue in many situations, we should expect the same. We should expect honesty and truthfulness and commitment from the patient in as much as we're giving to them. And that feeds into some of the ethical justifications that may seem on the surface to be a little rough from an emotional perspective, but justified in the situations where patients simply are not engaging in the fidelity aspect of the care that we're providing them. And these are just a partial list of virtues. And, you know, we look at principle-based medical ethics, virtues-based medical ethics. Principles give us guidance. Virtues are how should we behave, or how do we inherently behave. If you look at interviews of medical students and those that lean towards medicine, even nursing, you'd see these personality subtypes: compassionate, empathetic, courageous, honest, altruism, equanimity. Ironically, many of these are the same reasons that we tend to lean towards burnout as well. So is it okay for us to say no, but not patients? Or why is it okay for us to say no, but not patients? Well, I mentioned that there are derivative values of all those ethical principles. One of the derivative values of autonomy is a notion of positive rights and negative rights. And unique to Western medical ethics and legal interpretation, negative rights in Western medical ethics outweigh positive rights. So simply put, a positive right is a right to something. On the behalf of patients, it's mostly, we look at it as a right to honesty, to as corrective diagnosis as possible, to information, to alternatives, benefits of therapies. Negative rights are very simply the right to be left alone. It's the right to say no or thanks, but no thanks. Any non-Texans in the room? Or practicing, I should say. Yes, you're a little bit far from Texas. Okay, so everybody here, Texas physicians. It's important to know that in the infinite wisdom of our state legislature, that even non-competent patients can practice negative rights. Full tilt. Okay, so if you have a non-competent patient who's verbal, and they say, don't take me to the OR for my infected leg because I'm floridly schizophrenic in the moment and fear that I'm going to be infected with aliens, we're constrained. Now, what do you do in those situations? You get an ethics consult. But the point is that negative rights far outweigh positive rights. And that's one of the struggles that we have, I think, from an emotional care perspective. Here we are trying to uphold beneficence, non-maleficence, but you're telling me the patient can say no. Now, it's much harder in some situations when the patient is actually competent, because it's hard to navigate that and negotiate their way through it. And there's a strong legal argument behind this. As a matter of fact, this notion of negative rights and positive rights has been around for a long time. It's what led the Supreme Court to make their ruling in the Karen Quinlan case in the early 1970s, which gave rise, honestly, to our end-of-life approaches in medicine. Our ability to withdraw life-sustaining therapies was based on this notion that this young woman had a right to be left alone. She had a right to privacy, is actually how they came to the argument. It went from privacy to the right to be left alone. So that is the context by which, yes, we do respect our patients who say no, as frustrating as it can be. Is there such a thing as an individual or situation that simply can't be fixed? Well, I think we would all contend that's a sad reality. I'm going to share another case. I'm naming this young man Kevin. And this was what Kevin told us when we first met him from the Supportive Palliative Care Clinic Service in December 2017. We don't typically see pre-transplant liver consults as a matter of care planning. We do see our heart and lung transplants. This was a special case. The team was torn. This young man had a myriad of medical conditions. He had both PSC as well as Crohn's disease, I believe. And the team was torn. He had a long-standing history of poor compliance. He was 22 years old at the time, so again, a very young man, and an overlapping personality disorder that had been clearly defined by psychiatry. And he'd already established patterns of noncompliance, predominantly with self-neglect, so just not taking his medications, not upholding. And this was sort of the vibe that we got from the treatment team. This was the angst that we heard when we first got called. He's only 22 years old. What do we do with him? And the treatment team was torn about what approach to take. You can imagine he was a long-established patient. We had surgeons on the case. We had hepatologists. We had gastroenterologists. We had a large group of individuals. And they were torn with, do we move forward with transplantation because he's so young? And the empathy inside of us is driving us, the beneficence inside of us is driving us to want to help this young man, have him commit to behavioral contract, which I'll tell you carry no legal weight, acceptance of his noncompliance and simply continue to tread water, just do the best we can, or parentalistic refusal to transplant, a strong recommendation for encouragement for hospice enrollment. Our recommendation was to tread water. Just do the best we can. We don't have to necessarily go on to transplant, but don't abandon him. Continue to treat him as optimally as we can, understanding what's going to unfold. He was ultimately transplanted, and things, as you can imagine, if I'm presenting the case, didn't go so well. His compliance was not long-lived. His primary hepatologist was literally begging him, Kevin, you've got to come into the hospital. His Billy was clear up to the 20s, 30s, and just not taking his meds. On December 13th, we had a family meeting with Kevin and his mother, and he was discharged the next day with the agreement to tread water, and he ultimately enrolled in hospice, and I think he had passed within 3 weeks after leaving. That quote is actually what his mother shared with his gastroenterologist and myself meeting privately, and it was slight paraphrasing, but she shared with us towards the end of our long meeting, I just don't think he was meant for this world. I don't think he had the inner strength to be alive this go round, and she kind of alluded to the notion of maybe coming back another cycle. But even his own mother just basically said he was never meant to be compliant. He just was never meant to take care of himself. So that takes us to this notion of futility. How do we know futility when we see it, and how do we define futility in medicine? Futility is simply failing to gain the desired effect of an intervention. Historically, our sequence of how we've come to an appreciation of futility in medicine, we first started with the quantitative definitions in the 1960s. And we said, well, if said treatment exceedingly fails in a certain situation, then it's futile. The problem became, well, what's that cutoff? What's that percentage cutoff? Is it failing 95%, 100%, 90%? So we quickly realized that's going to get a little sticky. How about qualitative futility? Qualitative futility is really intrinsic to the individual itself. It's much more niche specific. It can't be defined by another individual. I always try my best to politely correct my nursing colleagues and physician colleagues when we're rounding in an ICU and they say, oh, this is just terrible. This is a terrible quality of life and this is futile. Well, credit to your amazing clinical skills, you're actually physiologically keeping this person alive. The futility in it, or the qualitative futility, can only be defined by that individual. You may not want this, but it doesn't mean that we can necessarily apply to them. The problem is if that individual's lost their voice, we don't know what their definitions are of qualitative. There's physiologic futility, which most of us can agree we know it when we see it. And it's very biologically based. It's a full systemic failure, okay? It's a colopulmonary fistula with ARDS and no effective immune system. So physiologic futility, I think, is really kind of where we lean more towards, has a very strong clinical basis, and you can imagine there's a lot of tie into qualitative futility as well. How about psychosocial behavioral futility? It exists in the setting where the physiologic disarray is bad but manageable. Okay, we could manage this. We have anti-rejection medications. If you would just take them, your liver will function for an average of 15 to 20 years. However, there's a long-established, typically, pattern of unrelenting behavior, recalcitrant noncompliance, recalcitrant drug abuse, recalcitrant homelessness or other factors despite offerings of help that sabotage our efforts to help. So it takes a physiologically bad situation and turns it in ultimately to an untenable situation. Yes, the person's going to die from their liver disease, their infective endocarditis, X, Y, or Z, but it really honestly is the psychosocial behavioral patterns that are really driving that towards that futility. It can also be enhanced in the setting of poor social support, which we see very commonly in the state of Texas. Again, there's the psychiatric definition here for a reason. There's oftentimes an overlay of personality disorder, and the end result is nonetheless a futile situation. And that's really what we were seeing unfolding with Kevin, was this behavioral pattern of psychosocial futility. So what are strategies we can employ to help ourselves? Well, I think we could take lessons from Kenny Rogers, and I had a medical student with me recently and said, you know Kenny Rogers, right? She was like, no, I have no earthly idea. I said, the gambler, know when to hold him, know when to fold him. No, I don't understand you, Dr. Casanova. That's what, shit, I've gotten old. But I think there is something to be said for the wisdom of the gambler, is acknowledging, listen, it's not abandonment. I'll be with you. I'm going to tread along right by your side. But our efforts to cure this underlying entity to in the setting of an individual who's been overmastered are done. Hippocrates didn't say we should run away from these individuals. We go back up to point number one. Point number one was affordance of comfort. Okay, very hard for us to do, but I think fundamentally important. And again, we need to differentiate this notion of abandonment from journeying along. I think we can close with guidance from the prayer of Maimonides. In the first line and the last line, the eternal providence is appointing me to watch over the life and health of thy creatures. And in the last line, O God, thou hast appointed me to watch over the life and death of thy creatures. Here I am ready for my vocation. I turn to you. I turn unto my calling. So I'm going to close there, leave a few minutes for any questions, comments, retorts, disagreements. I'm a pretty easygoing guy. I can take it.